The question for today is going to be, who deserves access to the full spectrum of medical treatment for the obesity disease? And this topic's been kind of controversial, especially when we talk about folks who are at the younger end of the spectrum, at the not so heavy end of the spectrum, not so sick end of the spectrum. I'm going to refer to this group of younger, not so heavy, not so sick people as soccer moms. And Serena Williams is another good example of this group. Serena has been blowing this topic up since about August of 25 with her disclosure and leadership that she's engaging with GLP medicines to get her obesity disease under control. Serena has had a lot of good things to say on this topic, but I think there's more to say. I come to this topic as a bariatric surgeon. For my whole career, my patients and I have been struggling against restrictions on access to care, and these restrictions I think often aren't based on risk-benefit or cost-benefit considerations, but instead they're based on weight stigma, or what I'm going to call obesity prejudice. And I think we're seeing the same dynamic play out as the GLP medicines become available. Now, the GLP medicines have become amazingly popular for weight control, and they're very effective. And in the 2022 to 2024 timeframe, when demand for the GLP medicines was surging and supply hadn't caught up, there were some supply constraints. And during that time, I think it was appropriate that the meds were given or allocated mostly to the people who were the most ill with their obesity disease, talking about the advanced diabetics and the really severe obesity patients. But the supply problems have been taken care of since the basically end of 2024, and yet the carping continues. Yet there still continues to be criticism of people who use GLPs for more modest weight control, for earlier stage obesity disease treatment. They're being accused of vanity treatment, or taking the easy way out, or cheating, or taking shortcuts. I want to speak against that perspective today in this video. I'm going to break this down into 5 themes against obesity prejudice. First of all, I would say that medical treatment is not vanity, it's health. It's not cheating, it's living. It's not a shortcut, it's actually part of a strategic plan. And by the way, quick fixes are usually fake fixes. And last of all, I think that early treatment is the best. Early treatment is the best because it doesn't need to be as intense, and so it's less risky, and because the metabolism isn't broken at the early stages, and so the treatment's more effective. I feel I should unpack the other side of this discussion just a bit. I've been calling it obesity prejudice, and that might be a bit harsh, not constructive perhaps. And so let's say that it's an old, outdated paradigm. It's the obesity as a choice paradigm. And the obesity as a choice paradigm was the dominant paradigm for generations and generations until science, beginning in the 80s and 90s, began to show us a different way, the more accurate obesity as a disease idea or paradigm. But the obesity as a choice paradigm was just given to many people as part of mother's milk, and even intelligent people may hold this idea because they just haven't gone back to thoughtfully examine it. Obesity as a choice believes that it's all about calories in and calories out, and that through will and focus and discipline, one can reduce the calories in and increase the calories out to lose weight. And it's tricky because this can work for a period of weeks or months. I mean, watch the TV show Biggest Loser, but it doesn't take account of what the body's doing in response to that weight loss, and the body doesn't like to lose that weight, as I'll explain in a little bit. And so even if you look at Biggest Loser contestants, unfortunately, all those folks regain their weight. That's the rest of the story. It's not just calories in and calories out. It's not just discipline and will and focus. It's what's the body doing in response to these things as a survival response. I promise in a minute I'm going to present some of the developing science that supports my claim that obesity is a disease and not a choice, and not a failure of will or a failure of discipline. But first I want to explore, there's this interesting angle about how the obesity as a choice narrative can be flipped around to support positive feelings for people who happen to be healthy and attractive at this time. See if this sounds familiar from social media. It goes like this: well, not only am I hot, but I deserve credit and praise because I worked hard to get this way. And I know how that goes. That what's being said there is that work, lifestyle work, leads to health. And I think it's absolutely true that lifestyle work is necessary for sustained health and attractiveness, but I think it's missing the fact that before the lifestyle happens to get success, there needs to be good genetics. And after the genetics and before the lifestyle, there needs to be a positive upbringing. In other words, the person needs to have been exposed to a healthy environment. We're talking about avoiding factors that stress the system and create obesity, and then lifestyle. And so if you're paying attention, you might have noticed that 2 out of these 3 factors, the genetics and the upbringing, are luck. And so people who don't have an obesity condition are actually more lucky than they are smart and dedicated. No hard feelings, guys, but this is what I think. And we see this in so many people who suffer from the obesity disease. They can kill it on the lifestyle piece. Lots of exercise, healthy eating, and yet the weight persists, the metabolic disease persists because their genetics aren't there as a foundation, or maybe their upbringing wasn't quite as good, things that were not their fault. And so once you lose some of the other supporting structures, maybe 2 out of the 3 legs of your metabolic health chair, then lifestyle alone can't get you to a healthy place. That's where medical treatment may need to come in. One more little thing before we get to that brief discussion of science I've been promising. Let's look at Serena as a prime example of how the obesity as a choice narrative doesn't fit with reality. I mean, come on, here is an elite athlete who performed in this highly public endeavor, stayed at the top of her profession for a couple of decades. She demonstrated levels of work and commitment that obesity doubters can't begin to claim. She is a paragon of discipline and focus and commitment. Furthermore, Serena had a lot of resources when she was trying to lose her weight. Now, this comes after she had a couple of pregnancies. She had gained some weight, and she did the lifestyle things. She did a lot of exercise. She knows how to do this. She ate right. She knows how to do this. And Serena has lots of support, not only in terms of coaching, advising, but in terms of time and money and resources and the ability to do all the gym things. And she couldn't do it with lifestyle. I promise you, in my job, I've met many, many other people who are amazingly dedicated and focused and hardworking, but the weight doesn't come off for them either. And I would say to you that Serena and the soccer moms and all these other folks who suffer from the obesity disease, they need to have next level options. They need to be able to step up the intensity. Now, the emerging science about this metabolic obesity disease, it fits with the experience that Serena and so many other millions of Americans have had, meaning that people gain a bit of weight, they do the work in terms of lifestyle with healthy food, lots of exercise, and the weight doesn't move, or it moves temporarily and comes back. And the metabolic disease continues to march along. And this is coming from a powerful control system. What do I mean by control system? Well, I think everyone's familiar with the fact that there are multiple control systems for key physiologic parameters, like, for example, blood pressure, temperature, some invisible physiologic parameters like blood sugar or potassium, and many, many others. And so it shouldn't come as a surprise to know that there is also a powerful control system that manages the human's energy storage, because we need energy to move from place to place. We don't eat constantly, and so we need a set point or a set level of energy storage. And we're still learning about all the nerves and hormones and organs that work together to manage this energy storage or this set point. But this diagram from Springer will give you just a superficial idea about all the multiple interlocking control systems that work on a constant, automatic, unconscious survival level. And I say survival level, so the goal of the system, the goal of the set point, is to do its best to keep the energy storage to a level that will optimize survival. Now, there's going to be a caveat on that goal and the success of meeting that goal, but I'll come back to that in just a second. But let's think about the blood pressure aspect of things for another minute. You know, we talked about how Serena gained some weight during her pregnancy and then she couldn't shake off the excess weight. It may also happen, and I don't know Serena's situation, but it may also happen that pregnancy leads to high blood pressure. And sometimes that high blood pressure doesn't go away when the pregnancy is done. And high blood pressure is initially treated with lifestyle, but we physicians aren't very patient with the lifestyle. If it's a month or two and the lifestyle isn't getting the blood pressure under control, talking about low salt, a healthy diet, and things like that, then we're going to add medicines in. So what if Serena now had announced that, okay, I'm taking losartan for my post-pregnancy blood pressure problems, not that she announced I'm taking tirzepatide for my post-pregnancy weight gain. I think that in the case of the blood pressure medicine, social media would have had a big, oh, I don't care, ho-hum. And the science says that we should have the same medical approach to the management of obesity disease, this medical obesity disease, as we do to blood pressure. And what I mean by that is that we should start with lifestyle, but not be exceptionally patient about it. If lifestyle isn't working, if it's not getting the thing improved, then we should move on to more intensive therapy. And so A moment ago, I said that the energy control system has the goal of optimizing survival rate, but in the modern world, it often doesn't work correctly. So people are born with different genetics or settings on the control system that have different levels of susceptibility to the different modern factors that they're exposed to. And I say modern factors, I'm talking about chemicals in the food supply, I'm talking about reduced activity in comparison to evolutionary standards. I'm talking about, even when we talk about natural food, it is excessively available. It comes on a very regular basis. And so these manipulations, these modern changes in comparison to what the genetics were prepared for, in many people, not 100%, in many people cause the set point to be abnormally elevated in a way that is stuck at a high level that's actually not adaptative, but it's also not a choice of the person who suffers from that problem. Now, I don't know anything about Serena's actual medical history, but from the outside, it looked like she's someone who is genetically predisposed to just a bit of excess weight. And for her life up until this time, that tendency was counterbalanced by her fanatical workout schedule. So credit for that. But then she had 2 pregnancies, and pregnancies are physiologically very stressful, and those pregnancies pushed her set point up out of bounds. And she also got a little bit older. I mean, the calendar's a bitch, right? So she had some expected slowing of her metabolism with that. And other folks have different genetics, different stresses, different timing. But the bottom line is that with the set point gets pushed up through different reasons for different people to an abnormal level, and it's basically impossible to correct the weight and the metabolism with lifestyle alone. So Serena gained some extra weight. She wasn't able to shake it off, but she didn't look like she was dying right now. She's still fairly young, especially from my perspective, and she had a lot to look forward to. She could have cruised along, gain a bit more weight gradually over the years, maybe intermittently get intense with the diet and exercise, lose 5 to 10% of the weight, take off a cholesterol medicine, take off a blood pressure medicine, but then kind of have an ankle injury or something, have a stressful life event, get off track, and gain the weight back with a bit of extra. And that would have been the standard American approach to this obesity problem, and it would have been the right way to lose weight. And that is what Serena did up until a point. But being the champion that she is, when she tried the standard approaches and they didn't get her to where she needed to be, she chose to take a different path. She has the accomplishment and the courage to choose not to accept the old failed ways. And yes, she sustained a foundation of healthy nutrition and serious exercise. That should be done. But now that those foundational interventions have been insufficient in her particular case, she's publicly declared her choice to add GLPs to her foundational lifestyle intervention. And I say more power to her. Serena intends to be an example in this way. Engage the basic lifestyle interventions first, and if they're not working, don't get stuck, but actively seek other options for therapy. What about Serena as an example of all the millions of Americans who are in their 20s to 40s, have a bit of excess weight, maybe not obvious medical problems right now? And I don't know all of Serena's medical history. I don't know if she had high blood pressure or diabetes or fatty liver or sleep apnea. She did say she was having joint and total body pains, which is sadly common because the excess weight causes total body inflammation. And maybe the details of her medical history are out there on social media, but my point right now is that the decision to intensify medical therapy isn't just about Serena today. Maybe she's not sick today, but it's about Serena for the rest of her life. We need to think about the next 30 to 50 years and how we're going to help her maintain optimal function and longevity. After all, she's got 2 kids. And imagine she wants to be in good shape when those kids graduate from high school and in the fullness of time when Serena has grandchildren. She wants to roll around on the floor with those grandchildren. And the best way to get there, I hope this is obvious, is to start treatment early. Every medical condition is treated better when we start at the beginning of the disease with the appropriate intensity of treatment. It has less progression, less damage, and less risk because the intensity of treatment doesn't need to be as severe. So let's also think about all those soccer moms in their 20s and 30s, and this is doubly true. We need to think about what's going to happen to those folks over the next 50 to 70 years and to start the treatment now and not get behind the power curve by starting it later. So I'd like us to support Serena and all the soccer moms and all the soccer dads too, as they engage in this lifetime project of seeking the best practical health. They should have access to all the tools that are available and all the developing science that makes sense in their individual medical situation. It's not vanity, it's a quest for health. And if we start thinking it's vanity, let's just take a breath and check ourselves for envy, perhaps. Maybe I've convinced you that GLP medicines and other treatment can be appropriate for folks who have early stage obesity disease if they're doing all the right stuff with lifestyle. And the next question that's going to come up is, what if someone's not perfect with lifestyle intervention? Do they deserve treatment? I mean, Serena's standard is a very high standard to reach. Does everybody have to get to that level? Do these real human beings deserve medical intervention if they aren't being perfectly compliant? And I contend that the answer is usually yes, if they've done the best they can do in their own individual life. And I want to call your attention to 3 facts. Number 1, nobody is perfect. Let's be honest, nobody is perfect. Number 2, the metabolic disease actually actively interferes with this compliance with lifestyle. In other words, when a person is cutting down their calories, the disease stimulates appetite. When someone is trying to exercise and is losing weight, the disease will make it feel bad to exercise. Those of us who haven't suffered from this problem have a hard time understanding how impactful these sensations are. And patients are frequently amazed at how different they feel with medical or surgical intervention when the food noise shuts up and the total body pain settles down. That's number 2. The disease fights back. It's hard to be perfect when the disease is fighting back. Number 3, most folks with excess weight and a sick metabolism also have busy lives. There are jobs and kids and spouses, etc., not necessarily in that order. And I'm not taking anything away from Serena on this part of the topic, but I bet that 99% of our patients have less time and less support than she had in her efforts. And yes, I'm actually saying that it is okay to use meds and other treatment to some degree to substitute for perfect lifestyle intervention. Say it with me, it's not a shortcut, it's part of a strategy. And credit to Serena for talking about this process publicly as a journey. There's no way that her weight and metabolism are going to stay fixed without ongoing continuous medical intervention, and people who expect a silver bullet or an endpoint treatment are stuck in the old school thinking. The reality is that we don't cure the obesity disease, we manage the obesity disease. And likewise, there's basically zero chance that Serena's current lifestyle and medication plan will be the right plan for her in 10 years or even 5 years. Serena and all the soccer moms should expect active, sustained, long-term management, but it's worth it. So say it with me, quick fixes can be fake fixes. Maybe at this point I've convinced you that using medical intervention for early stage obesity can be a good idea, and I want to shift over into some practical thoughts about how to get that done. And Serena's journey here again is instructive. I think that part of what she's done is public advocacy, changing the conversation, reducing obesity prejudice, but part of it is a well-constructed marketing campaign to bring people into the telehealth options. She is associated with Row Health, or it could be Hims and Hers. What about telehealth options for obesity management? All of us have become kind of more comfortable with virtual options. We like to order our food virtually. We don't like those messy interpersonal interactions sometimes, and especially when it's kind of an emotionally sensitive issue like the weight, maybe telehealth is the right place to start. And telehealth, at least on a token level, does have options for lifestyle coaching and intervention, as well as prescribing meds. And so it's not awful. But I want to point out that right now, 40% of the American population already has a body mass index greater than 30, which is associated with significant disease. And so I think most people who engage in this process are going to need to go beyond telehealth. Let's start with telehealth. There's no problem there, but don't feel bad or don't get stuck if you need a direct local advocate who can give you full spectrum, integrated long-term care, including the metabolic management piece. I also want to comment on the weight loss results that people are likely to get from these GLP medicines and how the medicines can fit into a full spectrum plan for managing the obesity disease. The Row website quotes that tirzepatide will result in 15% average body weight loss. And that probably is an accurate representation from the FDA research trials where tirzepatide was used under ideal conditions. But studies of tirzepatide and other GLP use in the wild, meaning out in the medical community, haven't been as good. And for example, the renowned Cleveland Clinic and their weight management program has found about half of that 15% weight loss with their use of tirzepatide and other similar GLPs. My point here is that I don't want us to get stuck on just one intervention. Again, it's a full spectrum approach. I've been advocating for us to get past the obesity prejudice and obesity stigma and to recognize that people with the obesity disease, even at the early stage, deserve access to the full spectrum of modern obesity treatment. The next question that comes up is, can everyone afford this? And the answer, unfortunately, here in 2026 is a big fat no. Insurance coverage for GLP medicines is very restricted. Insurance coverage for surgery is still restricted in comparison to where it should be. I think this comes from the fact that the obesity as a choice narrative has been the dominant narrative over the past couple of decades, and that narrative has prevented policymakers and the public from having a logical discussion about cost benefit and risk benefit that would help people get to the best level of health. And since we haven't been having that discussion, we haven't been treating this disease rationally. We've been in denial, and everyone has been losing. And I don't mean losing weight, I mean losing weight, losing health, losing in terms of having more adverse outcomes than they should. Fortunately, prices on the meds are coming down, and equally important, Serena and many other opinion leaders are moving the conversation more towards a logical approach, a medical approach to this health condition. I'm trying to do my little part as well. So I'm going to go a little bit out on a limb, and I'm going to predict that the administrative financial barriers to a full spectrum of obesity treatment is going to fade over the next couple of years. What will be left as barriers are going to be fear, stigma, judgment, old school thinking. I hope that more folks will choose, like Serena, not to accept their extra weight if lifestyle doesn't work, because any disease is easier to treat at earlier stages. The body doesn't suffer as much damage from the disease, and the treatment doesn't have to get as intense so that it's less expensive and less risky. Say it with me. Early stage treatment is safer and more effective. So I hope we're coming to a place where what we're after is the best health for everyone in our society, for all of our fellow citizens. And if they happen to become a little more attractive as they lose weight and get healthier, isn't that just a bonus? Let's go back to my 5 main themes. Number 1, it's not vanity, it's health. Number 2, it's not cheating, it's life. Number 3, it's not a shortcut, it's part of a long-term strategy. Number 4, quick fixes may often be fake fixes. It's a long-term deal. And number 5, early treatment is better. It's safer and it's more effective. One last thanks to Serena for sharing her journey and one of many reasonable paths. I wish you the best of luck on your journey to better health. You deserve it.